Welcome to this parallel session of the Global Assembly for the oral presentations on gender, sexuality, and everyday life related to health and allied health. So this session will be facilitated by me, Charlemagne Dayan Perez. You can call me Cha. I am a physical therapist and the gender focal person of the College of Allied Medical Professions of the University of the Philippines, Manila, the National University of the Philippines. Joining me here today is Dr. Evelyn Rojas. She is an epidemiologist and the gender focal person of the College of Public Health of the University of the Philippines, Manila. And this session is also facilitated by Dr. Carl Matthew C. Su, an anesthesiologist and the gender focal person of the UP College of Medicine, Philippine General Hospital. At this point, everyone must be excited to listen to our lineup of presentations to foster a nurturing and interactive environment during this session. We request everyone to please use your registered name and your pronouns to properly identify yourself as an attendee of this session. Please turn your video on during the session. Your audio and video settings are turned off by default by the application to reduce any disturbances, but we would appreciate it if we could see you throughout the session. Please be cautious at all times for everyone, and please send your questions and comments to Carl or here on the chat box for this session. We would love to hear from you, share your insights as well as your questions, and perhaps also participate later in our Q&A portion.
And today we will be listening to two oral presenters. Each presenter will share their research with us for 20 minutes each. We will then have a live question and answer segment after each one has presented. There is a scoring rubric that will be used to rank the presentations. The higher ranked presentation will be recognized, and the presenter will be given an award during the closing ceremonies. The following rubrics included in the guidelines sent to all presenters will be used to evaluate the oral presentations.
All right. So now let us listen to our first presenter. Glenn A. Cruz is a Development Management Officer assigned to the Facility Performance Management Division of the Health Facility Development Bureau of the Department of Health here in the Philippines. He studied journalism at the University of the Philippines, and in the past, he has worked as a copywriter for television, and he has engaged in advertising and public relations for agencies. He was a volunteer educator and trainer on HIV prevention among key populations and vulnerable communities before shifting careers to serve full-time as a program executive for a non-government organization working on public health and reproductive and sexual health and rights. In 2010, he moved to the Department of Health of the Philippines to work at the Secretariat of the Philippine National AIDS Council. Today, Glenn will be sharing with us baseline rapid assessment on the institutionalization of diversity and inclusion programs in healthcare facilities in the Philippines. Let's give him a warm round of applause.
Good day. My name is Glenn Cruz. I'm from the Facility Performance Management Division, the Health Facility Development Bureau of the Department of Health. I'm glad to join you here at the Global Assembly on Everyday Life, Gender, and Sexuality in order for me to present our paper, Baseline Rapid Assessment on the Institutionalization of Diversity and Inclusion Programs in Healthcare Facilities in the Philippines. I'm co-authoring this paper with Mr. Roderick Napulan, who is the Chief of the Facility Performance Management Division. As a matter of background, you would notice, of course, that globally, gender equality, diversity, and social inclusion as programs are being promoted in different places of work. In fact, the International Labor Organization comes up with researches and guidances so that different corporations and enterprises are able to develop gender equality and diversity, social inclusion programs and policies as a matter of upholding dignity and health in the places of work, as well as that there are also emerging international standards for organizations when it comes to diversity and social inclusion In fact, ISO has come up with ISO 30415 in 2021 that talks about human resource management, um, particular to diversity and inclusion. In the Philippines, the Executive Order number 100 was released by the President or issued by the President in 2019 so that the government can institutionalize the diversity inclusion program and create an interagency committee on diversity and inclusion. So mainly, the executive order talks about a national policy on diversity inclusion anchored to the country's commitments in the Universal Declaration of Human Rights and other United Nations covenants that in order to eliminate discrimination. It talks about an establishment of a national program that's aimed to eliminate barriers in equal opportunities, as well as consolidate existing laws and policies, rules, and regulations that combat or that address discrimination or resolve discrimination across the different populations in the Philippines. The involvement of the national program is applicable to the departments, bureaus, and offices of the government, including agencies, state colleges and universities, and local government units. The Interagency Committee on Diversity and Inclusion will be chaired by the Department of the Interior and Local Government, vice chaired by the Department of Social Welfare and Development. Of the 11 members, of course, the Department of Health is included. As a matter of study design, in June 23, 2021, through the Health Facility Development Bureau, the Department of Health issued Department Memorandum 2021-0291 to conduct a rapid assessment survey on the establishment of diversity inclusion program pursuant to EO 100. So the objective of the rapid assessment is to assess the establishment of the DIPs and the existence of policies, activities in health facilities that celebrate or actually observe the diversity of the workforce, as well as identify the needs in order to institutionalize the DIP. Approaches in this rapid assessment would include the issuance of this department memorandum and distribution with the help of the health facility development units in the regional offices of the DOH called the Centers for Health Development. And it includes a rapid assessment tool that takes up key structures or features of the EO 100, and there is a paper form that can be filled in and submitted, but there's also an alternate online form that participants or respondents can go to access and submit through Google Forms. So the certain areas of studies of this rapid assessment would include the promotion and protection of diversity as practice, and including a citation of certain instances, which is practice in terms of acknowledging different social categories. Mechanisms also on social inclusion, insisting certain systems, processes are sensitive to or observes the social inclusion processes that is necessary for a diverse workforce. And then also identification of needs in order to institutionalize the DIP in the healthcare facility. So you would see that in this report, EO 100's categories and mechanisms have been part of the rapid assessment. So particular social categories that are included in EO 100 are age, disability, national or ethnic origin, language, religious affiliation or beliefs, political affiliation or beliefs, health status, physical features, sexual orientation, gender identity or expression, or more commonly known as SOGI. Also, it also asks about the diversity and inclusion lens of certain mechanisms in the organization that are related to human resource management and development. So such processes as recruitment, hiring, training, promotion, retention, redress, or grievance platforms for the workers. So in terms of looking at the profile of the facility respondents, from June to July, we were able to gather responses from 66 66 healthcare facilities, but for this report we have excluded 2 because the submissions from the 2 submissions rather are needs further verification. As for the respondents by facility ownership, you would see that there's almost as much DOH facilities as private facilities, and there's just few LGU facilities that participated. There's by service capability, you'd see a large portion of hospitals, but there are also infirmaries and certain non-hospitals or other healthcare facilities. For these submissions, we were able to see some from treatment and rehabilitation centers related to drug abuse, and then psychiatric care facilities that are classified as custodial care facilities. A very large portion of the submissions come from the Luzon Islands. No? Particularly looking further into the different administrative regions of Luzon, a big portion actually comes from Central Luzon. There's very few from Visayas and Mindanao, only 3. In fact, there is 0 in Mindanao. The 3 here represents particular hospitals in the Visayas regions. And then there are also 9 from the National Capital Region. We ask first if of the healthcare facilities participating, if they have established a diversity and inclusion program in accordance or in accordance to the issued EO 100. So far there's around 13 DOH hospitals or DOH healthcare facilities that said yes, and there are 22 non-DOH facilities that have also answered in the affirmative. So one area of assessing the DIP in healthcare facilities is about the promotion and protection of diversity of the workforce. So it actually assesses or evaluates these particular social categories from SOGI to the political affiliations and beliefs, and you would see that almost all, a large portion of the respondents said that they were able to promote and protect diversity in their workplace organization. There are activities that are testament to their work in promoting diversity. So beside the gold or the orange bars are gray bars that actually are responses to the question of if they could provide whether there are instances where they could say that diversity is celebrated, or that there is respect for a diverse workforce in their organization. So these are particular top of mind citations of certain instances according to the different social categories. You would notice that there are others that are mentioned, and these are particularly referring to not exactly referring to the social categories under EO 100, but are some identification like certain situations of people's differences or workers' differences across the merit-based systems. So like people who are yet to receive their licenses, or people who have yet to undergo the proper training or qualifications for promotion. And there are also instances of saying that there is diversity in terms of people coming from different places of residence other than the municipality or the city where the healthcare facility is located. In terms of the mechanisms of social inclusion, you would see the different mechanisms in human resource management and development. And you'll see a big portion of instances, 63, the big gray bar, 63, showing that the instances is about having the organizations employ certain persons that fit the profile or that fit the social categories that are mentioned in the EO. So such as people of diverse SOGI that are entering into the service and as such. You would see that the others in this graph is is quite large, accounting for 34. This, in fact, is comprised mainly of the respondent suggestions of including for social inclusion, particular clinical or other programs of the healthcare facility, not necessarily the processes of human resource management or development. So these are more focused not on the workforce, but the workforce actually providing services to clientele that who might be coming from different and various walks of life. A large portion here is talking about indigenous. There's a substantial portion here that talks about the indigenous population. There's a large portion here talking about the indigent households, so clients coming from indigent households and being able to provide medical social services. So one important area of assessment that the Health Facility Development Bureau is interested in, especially when it comes to development of programs, health facility-based programs, is looking at the development of hospital development plans among the hospitals. So HDP is something that we champion and actually provide assistance to a lot of the hospitals, LGUs and the DOH hospitals. And particular to this rapid assessment, we would like to look at if the diversity and inclusion categories and mechanisms have been part of the developed or the formulated hospital development plans. So you would see a large portion in the analysis of gaps and needs for planning. You'd see that the gender diversity and inclusion lens is actually present in much of the DOH hospitals. Interestingly though, you would notice that there is more lens that is exercised on the diversity of people according to religious affiliations and beliefs as to health status or even disability or even age, which we have initially expected that would be the usual areas for analysis of the different sectors of the population when considering the development planning process of hospitals. There are others that from analysis into actually developing developmental directions and actions have directly translated from some of the DOH hospitals. These others actually refer to some of the categories that they suggested, such as the variety of cadre, the health cadre that is not needed for hiring or for placement in the different healthcare facilities in different places in the Philippines. So it is more related to the ability of organizations or the need of the organization to meet the staffing standards and having the expertise and the professions that are needed to have quality services provided to the catchment populations. So that's one part of the others. But you would notice that there's as much developmental directions according to social category in DOH hospitals as the private hospitals. This directly, I think, translates into the actual distribution of the respondents who participated in this rapid assessment. And the final portions, of course, of this rapid assessment is looking at the operationalization and the institution of the DIP in the healthcare facilities. This follows through from the health development, hospital development planning. So this final slides are actually referring to the hospitals that participated in the rapid assessment. Some of the hospitals said that these areas are the factors to consider in operationalizing the DIP. This is a plethora of different suggestions that have been categorized according to common themes. And you'd see that the top consideration is about leadership, governance, and the policy framework. It's about workers' literacy and competence when it comes to the diversity and inclusion. And it's also about having systems, procedures, and proper guidelines in place in the healthcare facility to ensure that DIP is in fact operational and producing the intended effects or outputs or outcomes, should there be an institutionalization of a policy. We are also, the HFDB, are interested in the technical material support for suggestions coming from the respondents, and we look at this closely because HFDB together with other bureaus are some of the technical leaders or the technical stewards of different areas of the healthcare delivery system. So we noticed that in the technical and material support that's requested, of course, there's fund augmentation that's requested for the funding of activities or the operations of DIPs, including placement of certain personnel to ensure that the DIP is properly staffed to function. But there's also requests for technical assistance and training opportunities to ensure that people are able to develop the right instruments, develop the right tools, and as well as perform the needed actions to operationalize the IP. And they are also suggesting certain campaigns that can be led by the DOH that that can unify and increase the profile and the awareness of people when it comes to the gender lens, the gender, the diversity and inclusion lens in healthcare and the provision of quality healthcare. In terms of focus for operations, there are different offices that are suggested, but most of them are related to the HOPS, or the Hospital Operations and Patient Support Systems. This categorization is based on the Department of Budget and Management and the Department of Health's joint circular on the revised organizational and staffing standards for hospitals. So you would see that because human resources and administrative services are the most common suggested offices to be involved in the operationalization of the IP, there's a large box for HOPS here. But of course, there's also top management, particularly involving usually the quality management system, as well as the PETRO, or the PETRO, the Professional Education, Training and Research Office or unit, involved in the generation of evidence and competency building of the healthcare workers in their organization. The others that are mentioned here are certain offices that are not particularly present yet from the joint circular. So I conveniently put it under others, but it actually includes the involvement or the suggestion that the occupational and safety office should be part of operationalizing the DIP. And of course, with finance, they're looking at the budget office, particularly, so that we are able to ensure that the DIP is well funded and operationalized. So for recommendations, the first and foremost recommendation is the establishment of the DOH own DIP framework and focal office. In fulfillment or in pursuant to EO 100, because before we started this rapid assessment, it was realized that the DOH haven't yet actually provided a framework or assigned the focal office for diversity inclusion. But we would also like to anchor one of the HFDB's programs, which is Integrated People-Centered Health Services Framework, because it mirrors particularly certain processes that are necessary in the IP. The IPCHS is a framework that is anchored to the universal healthcare goal of responsiveness of the healthcare facilities or the health service delivery networks that are assured under the universal healthcare mandate. The IPCHS is actually, as a program, is actually recognized and institutionalized by the Malasakit Centers Act. Now, also, one of the things that had been part of the feedback in this rapid assessment was of the lack of capacity for people to talk about diversity and inclusion, and getting people to understand what it actually means in the way they perform their work, or they actually be part of the team that delivers healthcare. So we might need to capacitate key persons to get the conversation going and to increase the sensitization, the need to sensitize the organization, as well as get the idea of the diversity inclusion program top of mind or on the consciousness of many of our workers. And then, of course, because it is provided in the EO 100 about integrating and consolidating frameworks and mandates, it's important that the connection with other stakeholders to further improve opportunities to align the alignment of diversity and inclusion should also happen in the manner that is needed and that can be supported in a manner that can be supported to the healthcare facilities. And then also in relation to IPCHS, maybe we could also study how to diversitize and prioritize the D&I strategies, the institutionalization with different healthcare facilities, because in essence, not all facilities are hospitals. So there are different contexts and there are different sensibilities and sensitivities that have to be considered in the provision and the operations of the different healthcare facilities. As for us in HSDB, and particularly in our division, certain forward actions in working for the diversity and inclusion program, we might need to increase the participation of the underperforming regions. You see the skewedness of the contributions of Central Luzon and almost nothing in the Visayas and Mindanao. So we have to correct that underperforming regions and maybe extend the invitation for participation in the rapid assessment. But there are already intended initial dissemination of findings, one of which is actually part of my commitment when I finished my diversity and inclusion course from the Civil Service Institute. We'll be doing one internal to the Bureau to disseminate these findings and talk about diversity and inclusion during the campaign of ending gender-based violence, which happens in November towards December. And then internal technical coordination and support seeking would be important as part of our work already in the Bureau to talk about actually doing the DOH counterpart in institutionalizing BIP for the health sector, which of course, together with our findings in this rapid assessment, would lead to the possible development of a policy brief and a request for presentation, endorsement, and consideration of the DOH top executives. And finally, the production of a framework document of diversity and inclusion in healthcare services delivery. And with that, thank you very much. And I'm looking forward to conversing with you during the conference and providing further input in relation to this.
Project. Those are very interesting results of your rapid assessment. I'm sure that the rest of the participants present here today would somehow relate to those findings or would find it similar or perhaps different from what is currently implemented or happening in their own country. So it will be very interesting to have a dialogue with you later in our Q&A portion. I really look forward to that. But before that, we will just listen to our second presenter. Hannah Spencer is a UK-based occupational therapist with a particular interest in LGBT+, especially trans and non-binary identities. Hannah co-founded the recently formed LGBTQIA+ OT UK network and remains committed to the network's connect, share, learn, and celebrate ethos. A gender agenda was commenced in fulfillment of the independent scholarship component of the pre-registration MSc program that Hannah completed in 2020. Today, Hannah will be sharing with us a gender agenda on exploration of pre-registration occupational therapy students' understandings of gender, variance, and relevance to occupational therapy practice. Let's give her a round of applause.
Hi everyone, my name is Hannah Spencer, my pronouns are they and them, and I'm a UK-based occupational therapist currently working in mental health. Thank you for joining me for this presentation on my MSc research project, Agenda, an exploration of pre-registration occupational therapy students' understandings of gender variance and relevance to occupational therapy practice, which was submitted last year. Before I start, just to recognise that my personal interest and lived experience is inherent among the justification for this project, and therefore to acknowledge that potential for researcher bias and highlight my closeness to the topic area as both a strength and a weakness. Despite its limitations, however, this discussion arguably offers valuable insights relevant to occupational therapy and wider healthcare practice and pedagogy in the UK and beyond. So firstly, a mention around language and terminology, which relating to this topic area is something that's ever changing and unsurprisingly ripples throughout people's uncertainty. For the purposes of this project and presentation, for numerous reasons, I've used transgender or trans in its most encompassing form as an umbrella term inclusive of all gender identities diverse from sex assigned at birth and or the male-female gender binary. Sex being that usually binary, biologically indicated assignment of male or female at birth, and trans then as the antonym of cis or cisgender, which refers to people whose gender identity is largely congruent with sex assigned at birth. Though differences in cultures and societies worldwide must be acknowledged, it could be argued that Western society as a whole is assumed cisgender and perceives both sex and gender as binary, as either male or female, often overlooking the needs of those who are trans and or non-binary. In terms of context and importance of this study, I guess injustices trans people experience are well documented alongside those societal assumptions of cisnormativity in the context of the UK. Quotes on the slide there relating to healthcare stood out to me, particularly when we think of optimal health and access to healthcare as fundamental human rights. More specifically then, though the potential bias of documentation co-produced by an organisation with a specific campaign agenda must be acknowledged, those quotes on the left there were from a report published by Stonewall on the health of the LGBT population in the UK. 41% of trans people say that healthcare staff in general healthcare services lacked understanding of trans health needs. And 64% of non-binary and 60% of trans respondents felt like life was not worth living. Those figures and also qualitative outcomes relating to discrimination and abuse experienced by trans and non-binary people in healthcare and beyond further support relating that to occupational therapy practice in consideration of our patients and service users, our colleagues and our students across the diversity of practice worldwide, as well as increasingly diverse roles for occupational therapists in terms of proactive and preventative population health. And that third quote there, many LGBT people still face significant barriers to leading happy, healthy and fulfilling lives in Britain today. How can this not be relevant to our profession as we as occupational therapists ultimately support people to live, not exist? So those aspects previously mentioned highlight alignment in terms of our humanistic values, but what of our professional obligation? National and international codes of ethics and professional standards for practice highlight the fundamental inclusivity of practice. Specific to the UK, the Health and Care Professions Council, or HCPC, which is our registering and regulatory body, highlight in their standards of proficiency for occupational therapists that practice be non-discriminatory and utilise awareness of diversity. Similar echoes through documentation produced by our professional body, the Royal College of Occupational Therapists, which highlights importance of appreciation of and respect for diversity and individual differences and their influence on occupation and participation. And in the document which summarises the intended standards for entry-level occupational therapists produced by ARCOT, it's posed that graduates should be able to advocate for the rights of individuals, groups and populations in order that their occupational needs be met. The Association of Occupational Therapists in Ireland have produced LGBT plus good practice guidelines, which similarly highlight our professional obligation to practice in an LGBT plus inclusive, non-discriminatory manner, but also call for a need to address the knowledge gap in our profession. So a broad range of preliminary reading advised my search terms for a more comprehensive occupational therapy specific literature review, whereby individual strings of search terms relating to occupational therapy and gender variance were entered, followed by a third search which which combined the two. The search was replicated across 5 subject-specific online databases and supplemented by manual snowball searching, a systematic strategy which was revisited periodically throughout the course of the project. Without the space afforded here for more detail in the content of the literature review, I guess the results of the search were, in a sense, my first finding. There were 11 unique papers spanning a near 30-year scope from 1993 to the present day. And that relative scarcity, despite expansive time span, arguably further reinforces the need for research, especially in the context of occupational therapy as an evidence-based profession. So the need for research had been significantly highlighted throughout all of the aforementioned, really. Those healthcare statistics, that lack of occupational therapy specific literature, let clear resonance of occupational injustices experienced by trans and non-binary people, and highlighted reciprocal relationship between occupation and gender identity. And also that lack of visible, accessible commitment to expanding knowledge and understanding of the unique biopsychosocial and occupational needs of trans people. It was then the prevalence of lack of knowledge, uncertainty, and need for education as themes across that limited literature base, which aligned with my context of pre-registration education at the time. And that, combined with acknowledgement that pre-registration education fuels the future of practice and thus has a direct influence on the future of practice. Those aspects further defined the scope of my project and shaped the overarching research question, which was, in relation to occupational therapy practice, what are pre-registration occupational therapy students' understandings of gender variance? The project I undertook was a small-scale qualitative study. Following ethical approval from the institution, an exploratory approach was used with focus on depth of inquiry, insight and meaning. Data was collected through focus group discussions among a small purposive sample of pre-registration occupational therapy students as a single UK higher education institution. That purposive sample then being strategic and by no means representative of the population as a whole, but the focus group discussions meant that the data was created as organically as possible from the participants themselves. Informed consent, inclusive of audio recording, and a mutual agreement to maintain participant confidentiality and anonymity was obtained from all participants prior to data collection, with the information sheet about the study being kept intentionally minimal so as not to influence those participants' understandings of the topic area. Discussions were audio recorded and transcribed verbatim to facilitate subsequent critical analysis and synthesis with the literature. Focus group participants were also asked to employ first name pseudonyms to enable concealment of their identity, and I remained transparent throughout the process regarding my clear intention to share the research findings. Thankfully, all my data was collected and complete prior to lockdown and the COVID-19 pandemic hitting. A bit about my participants. Within that purposive sample were students in pre-reg occupational therapy education that were specifically able to draw on both placement and academic-based components of their training, which meant that there were 2 cohorts excluded from participation because they hadn't yet been out on placement. Participants unanimously agreed this topic area to be highly relevant to occupational therapy practice. Initially considering this specifically in gender identity or mental health services, but through discussion, collectively acknowledged that trans people have health needs aside from gender identity and recognise the diverse settings that occupational therapists work across. There was clear consensus of gender identity being at the core of a person, and that alignment or lack of alignment relating to gender identity is something that influences a person's feelings, values, sense of self. Participants largely reflected on their perceptions of the detrimental impact of essentially having to hide one's true self or negotiating that kind of self-acceptance and actualization, often in a way that's largely hidden. Through discussion, they then arrived at the opposite, at the process of becoming, in terms of coming out and transition, being aligned with being and becoming one's true self, and how much occupation was inseparable from that. highlighting then that complex and intertwined relationship between gender and occupation, which is all the more conscious and evident in this population group. That theme of doing gender and all of that being all the more conscious and intentional in this population group is something that also ripples through the literature, however limited that was in supply. Whether consciously or less so, roles, habits, patterns of doing and motivation for doing are all influenced by gender and societal expectations of gender. Occupational choices are a means of projecting or constructing desired identity, examples being occupational engagement overtly congruent with gender identity to reinforce or to affirm, or on the contrary, occupational choices overtly congruent with sex assigned at birth so as to conceal gender identity. The influence of multifaceted environment on occupational engagement and healthcare settings and professionals as part of someone's environment were again dominant themes in discussion. Participants talked of the environmental barriers to occupation, including definition of many physical spaces as binary, as either male or female. And exploring that, they talked about healthcare environments, separate wards, treatment in binary contexts. They talked about occupational environments, for example, sports and fitness settings, gyms, leisure centres, locker rooms, changing villages, and so on. And they talked about gendered occupations in terms of specifically team or competitive sports, employment and societal stereotypes, and also talked about the impact of social environment and societal attitudes. Participants also talked about losses and sacrifices, but also occupational transitions and occupational gains, learning new ways of doing that were parallel with gender transition. And their understandings in that discussion largely paralleled the content in that limited literature base, whereby binary physical environments, including healthcare environments, the disempowering social environments and mental health implications of such were dominant themes. Participants acknowledged their uncertainty and self-perceived lack of knowledge and understanding, which paralleled again those themes of uncertainty, doubt and lack of knowledge in the literature review. This was characterised by phrases such as "I don't know" or "I'm probably wrong, but," and largely related to language in terms of the differences between the terms, which are difficult to understand when not consistently or ever exposed to, and a fear of saying the wrong thing. Participants echoed that they would ultimately listen to and learn from patients, but contrasted that with the notion of knowledge and understanding being a key determinant of therapeutic relationship. Arguably, it's then a balance between recognition of the unique experience of each individual, but also synthesizing that with existing professional knowledge and insight. So the context and content of pre-reg occupational therapy education was fairly plentifully discussed as influences on perceived knowledge and understanding. In terms of content relating to gender diversity within pre-registration occupational therapy education, participants spoke quite clearly and strongly of a lack of and need for more. They also cited the media, especially social media, as an information source, which again prompts caution when considering occupational therapy as an evidence-based profession. And that essentially takes us full circle, relating back to that plentiful evidence, which highlights that inadequacies as far as knowledge, understandings and attitudes towards trans people are still rife in healthcare settings, and highlights the widespread need for increased understanding of trans healthcare needs. However sparse and limited by locality, scope, scale and quality our occupational therapy specific evidence base is, it tentatively suggests the same, with studies such as those by Boulding et al. 2020, Dowers et al. 2019, Acker 2017, which relate increased education to decreased phobic response and prejudice, and acknowledge practices most successful with some foundational knowledge of specific needs of particular population groups, inclusive of health inequalities and occupational injustices. And those there's quotes that I've pulled out there from the studies, the lack of knowledge negatively affecting health and well-being, and the frustrations at constant disclosure and having to educate healthcare professionals. Though broadly considering the LGBT plus population as a whole, rather than specifically trans people, a further systematic review by Hunt et al. 2019 reiterates that posed by the UK Government Equalities Office, Stonewall, etc., around the importance of effective training and education for health and social care professionals around LGBT plus specific needs post qualification. But this could arguably, as participants in the present study emphasised, be proactively addressed through pre-registration occupational therapy education. Small scale and specific to one institution and the subjective experiences of an under-recruited sample within. The findings of this study are not necessarily reflective of occupational therapy education or practice across the UK, let alone globally, or indeed sufficient a sample to be representative of this context itself. What it does do, however, is raise to the surface some of the issues that have clear need to be discussed in the context of reiterated and emphasised relevance to practice, and offer contribution to a clearly incredibly sparse occupational therapy specific evidence base concerning a population which conversely experience diverse and considerable occupational and health injustices. Trans people access both general and specialist health, social care and voluntary sector services across a range of provision. Reasons for doing so may be related or unrelated to gender identity. Trans people experience diverse occupational and health injustices and barriers to occupational engagement, performance and participation, both related and unrelated to gender identity, which occupational therapists are ideally placed to support. This study highlights the relevance of and necessity for understanding of diverse gender identities in occupational therapy, particularly considering the diversity of practice. Arguably, to continue to overlook this population group is something that conflicts with those underpinning holistic and humanistic professional values. So though this study was small and tentative in scope and scale, findings seem to echo those acknowledged elsewhere, with clear recognition of a need for further research, increased knowledge and understanding, and furthermore, visible commitment to the unique occupational and health needs of this population group. And this study poses that pre-registration education is the appropriate and necessary starting point for doing so. Thank you for listening. There's my references. And a few acknowledgements, particularly to Helen Brown, who supervised this project.
Thank you very much, Hannah, for discussing your research to us. At this point, I'm sure that everyone in our meeting is probably excited and thrilled to ask their questions and share their insights for our speakers and our presenters. We'd like to essentially remind everyone that they can type in their questions on the chat box in one of the tabs below, or if you wish to verbalize or voice your question yourself personally or live, then you may raise your hand and wait to be acknowledged by yours truly, so that you could address your question to Glenn, Cruz, and Hannah Spencer for them to answer live. So unfortunately, we did start a little bit late, so we will have around, I think, about 5-10 minutes to entertain questions for Glenn and Hannah. So I hope you have your questions ready so that we could ask them. So I'd like to invite back Glenn Cruz and Hannah Spencer to the virtual floor so that they could answer some of their pressing issues and questions and comments from our attendees. Okay. The first question would be for Glenn. Glenn, in your rapid assessment of DOH facilities and hospitals, were you able to note also if they were able to actually have diversity and inclusion educational programs that is mandated to be implemented in the executive order signed in 2019? And how did your respondents react or received these particular information campaigns and programs?
Well, thank you for that question. Is my audio okay? At the moment? Yeah, okay.
Yes, Glenn, we can hear you.
Yes. The short answer to that is no. There are no educational programs that is related to diversity and inclusion, which in fact, it actually reflects on the way our respondents actually gave their responses. When we say that if you think that these social categories are in fact protected or respected in your diverse workforce, what are the instances? And the usual instance is that they could identify somebody who fits that profile and actually is hired by the organization or placed in a particular service. But I have a sense that the more that we got into the questions of the things that they do, especially on social inclusion, what are the mechanisms? Training and education is very scant. And in fact, when it comes to the recommendations on what are the decisive factors or what are the factors to operationalize the program, you would see that it was in the top 3. There are not enough conversations ongoing, and they are, other than identifying who the people are, or having a sense of who are part of their diverse workforce, they don't have anything else to offer when it comes to operationalizing the DIP, which is very interesting because I noticed that in the instances that they say that they are actually respecting diversity, the easiest to identify are the diverse religious affiliations as well as SOGI. And as for the rest, there's almost nothing. And in fact, some of the other categories that they are offering that should be observed are particular situations that are actually gender burdens. There's more than once that I noticed that there is, in fact, there are samples that they say that they have single parents who are women, and they think that promoting and actually giving space for workers who are single parents, particularly the single mothers, are a part of their are the main mechanism that shows that they have gender and diversity in the workplace.
Thank you very much, Glenn. So it seems that we still have a long way to go, and I guess,
Yes.
or there's a lot of room for improvement in terms of DIPs in our government agencies, and it's not enough that there's an executive order that mandates it, but the implementation is something that we need to really work on. Thank you very much. That's very enlightening. The next question is for Hannah. Hannah, sorry, I may have missed this, but how were you? How did you conduct your focus group discussions for your sample? Did you do a pre-testing of your questions, or was this a freely flowing exchange of ideas on trans needs and non-binary needs of clients and patients in occupational therapy? Because I'm really interested in doing a similar study, for example, in my field in anesthesiology.
Mm-hmm. Cool. Thank you for the question. Good to be with you today. Yeah, I intentionally kept any information really, really minimal. So from kind of a recruitment perspective, the information sheet was really minimal in terms of divulging information around trans and non-binary identities, because I wanted to understand people's kind of organic experiences and understanding without influencing that myself, and get a true picture. I had a small under-recruited sample, but from that sample, I wanted to get as much of a true picture of people's understandings as possible without having influenced that myself.
All right. Thank you.
Does
So
that
you're
answer
really,
your question?
yeah, I think so. So it was really a very organic approach. that you essentially very similar to like a man or woman on the street or not or anyone, essentially any person on the street type of interview. That's a
Absolutely.
very interesting approach.
So I basically started the focus groups with the acronym, the LGBTQIA+ acronym, and used that as a prompt for discussion, and asked people to draw on their understandings from OT education and clinical practice.
During this discussion, Hannah, did you have to clarify on specific terminologies that your respondents may have confusion on? For example, in my discussions with some of our early years of college students here in the Philippines, we essentially determined that there are some confusion about non-binary as well as gender fluid identities. And how do you address this particular confusion?
Absolutely. Sorry, the clock just dang. So during the actual focus groups, I didn't intervene. I didn't clarify. I let the discussion kind of clarify itself. And if there were participants that maybe knew more, then they threw out that suggestion. But that uncertainty and that doubt was a finding in itself, I guess. However, I did offer participants the opportunity to debrief after the focus groups had taken place. So if they had specific questions to ask then I could clarify, or I could signpost to further information. Again, different people have different experiences, and everybody's experience of gender is unique to them as an individual. So I could kind of interpret from my point of view and from the knowledge and understanding that I have, but always with that caveat that each individual has their own personal experience of gender identity.
Thank you very much, Hannah, for that clarification. That gives us a better grasp or idea of how you were able to conduct these studies and get the conclusions that you were able to derive. And that's an interesting way to end your focus group discussion by offering a debriefing that sometimes is forgotten in this particular methodological approach to a research proposal. Right. Do we have any questions from the rest of our guests? Well, we still have Glenn and Hannah with us, especially those who are very much interested in the fields that they've presented. It's very common among our participants to be shy, and it is pretty much dinner time now in the Philippines, Hannah. So some of our Filipino participants might be either in the process of cooking their meals or essentially partaking in them. So that might be, and we do try to be polite in terms of when it comes to these kinds of exercises. But I guess if they have any other questions for Hannah and Glenn, they can always send it to us and we'll forward it to you. And I hope you'll be able to answer them for the additional knowledge of our guests and our participants in tonight's activity.
Definitely happy to connect, happy to discuss at a later date. Yeah.
Thank you very much, Hannah. Thank you very much, Glenn. I guess at this point, we have gone through some of the questions that are available, and I'll now pass the virtual floor to Dr. Evelyn Rojas.
Thank you, Dr. Carl. And again, thank you and congratulations to our two presenters, Glenn and Hannah. So thank you for sharing the results of your study. So it will be a very tough task for the three of us because we'll be deciding to give an award. So we have to choose one. Anyway, so again, congratulations. At this time, do we have the certificates for our presenters? So let me read the certificate of recognition coming from the Global Assembly on Everyday Life, Gender and Sexuality. So presents the certificate of recognition to Glenn A. Cruz in recognition of your participation for the oral presentation entitled Baseline Rapid Assessment on the Institutionalization of Diversity and inclusion programs to healthcare facilities in the Philippines during the Global Assembly on Everyday Life, Gender and Sexuality, organized by the UP Manila CGWS in partnership with the SexGen Autos, held on October 29 to 30, 2021, via Zoom, signed by Rod De Los Reyes and Dr. Leilani Nicodemus. Thank you, Glenn. So same citation, certificate of recognition awarded to Hannah Spencer in recognition of your participation for the oral presentation entitled Gender Agenda, an exploration of pre-registration occupational therapy students, understandings of gender variance and relevance to occupational therapy practice. Thank you very much, Hannah. So thank you, Cha and Dr. Carl. So we still have, I think, 10 minutes before we proceed with the workshop. So for our audience or participants, you can still have a 5-minute break, maybe, Dr. Carl and Cha, right? Before you proceed to the workshop session. So we've sent the links already. So if you haven't pre-registered, they can still register so that you can participate with the 3 workshops.
Yeah. Thank you so much, Glenn and Hannah. We hope to hear from you again in other platforms, in other conferences.
Thank you.
Thank you so much.
So we will see you later in the closing ceremonies.
Yeah.
Bye.
Thank you and congratulations, Hannah and Glenn.
Congratulations, Hannah and Glenn.